This is actually a huge cohort of patients in the context of CRLF2-rearranged B-ALL. I worked on this with Dr. Jain. So here we looked at patients from 2001 to 2021, which is like 21 years, who had presented at MD Anderson with newly diagnosed CRLF2-rearranged B-cell ALL. We had 76 patients, out of which 11 were treated with augmented BFM, whom we have not reported here, but 65 patients who were treated with hyper-CVAD or mini-hyper-CVD based regimens have been presented here. Overall, the response rates are good, but the survival is not very promising compared to other subtypes of B-ALL. The median relapse-free survival was 17.6 months, and median overall survival was 26.6 months. But interestingly, what we showed in this study is that patients in both arms, hyper-CVAD or the mini-CVD. Now, it is important to mention that patients who received mini-CVD were of a more advanced age. Their median age was around 60 to 63 years. The patients with the hyper-CVAD was around 40 years, as is the usual protocol at MD Anderson to treat ALL patients. Now, across both arms, patients who received targeted regimen, which could be Inotuzumab or Blinatumomab, they had better relapse-free survival and overall survival than patients who received just chemotherapy, which is hyper-CVAD, without any targeted regimen. It is important again to mention that all mini-CVD treated patients get Inotuzumab, but there were some patients with hyper-CVAD who do not get any targeted regimen. So we compared these and found that patients with hyper-CVAD or mini-CVD versus with targeted regimen versus those who got only chemotherapy, there was a difference in their survival. Now, we also looked at, does transplant help these patients? And we found that the improvement in RFS or OS with transplant is preferential in those patients who are JAK2 mutated CRLF2 rearranged ALL. In patients who are not JAK2 mutated CRLF2 rearranged, transplant might not improve survival as much, and the transplant-related mortality might offset the benefits that can be accrued from transplant. We did univariate and multivariate analysis to look at factors which affect death at 2 years in the patients who were treated with hyper-CVAD-based regimens, so 51 patients. And we found that those patients who were treated with Inotuzumab or Blinatumomab-based regimens, or those who had transplanted, had, on univariate analysis, lower risks of death at 2 years, but on multivariate analysis, only the use of targeted regimen stands out as a favorable prognosticative marker for death at 2 years. So which is a very good thing, because essentially now in our center, we use targeted regimens for all of these patients. We try to give them early Blinatumomab, and it seems like with time, the prognostic significance of CRLF2 might reduce if we use proper targeted regimens. We do advocate transplant in these patients, but especially in the JAK2 mutated patients, transplant seems to be the most promising treatment option.